Hello everyone, myself Anuradha Rakhunde Khamkar. I am a sports physiotherapist and this is my first attempt of a YouTube video. Hope this will help you, and if you like it, please share and subscribe my channel. That is Aspire Physiotherapy and Rehab Center. Little bit about my career so far. I was previously associated with BCCI and was a venue medical officer for IPL matches. I was working for Mumbai Cricket Association for a couple of years. I was assistant physiotherapy at Mumbai Cricket Association, IDBI Federal Life Insurance Pace Bowling Foundation. Currently, I am working as a consultant physiotherapist at Optimal Performance and running my own physiotherapy rehab center as well. Now, this is all about me. Let's start with our first topic, that is athletic groin pain. I have divided this topic into two parts, part 1 and part 2. Part 1, we will cover groin injury statistic, that is epidemiology. Then we will discuss structural anatomy and groin triangle. Our third subtopic will be assessment, and the last one is injury classification. Now let's start with our first subtopic, that is epidemiology. Epidemiology of groin injuries will discuss something about soccer and non-soccer games as well. So according to statistics, groin injury in male club football accounts for 4 to 19% of all injuries and 2 to 14% in women. 29 studies found a higher proportion of groin injuries in men than women. Groin injury rates in male were 0.2 to 2.1 per 1000 hours of game, while in women it was 0.1 to 0.6. When playing the same sports, we can conclude from all these stats that males had a greater injury incidence of groin than. Now, studies in professional sports have found groin injury to be the fourth most common injury affecting soccer player. So after ACL and hamstring, I think groin is the more prevalent injury. The third most common injury in Australian rules football, and it is also have a high prevalence in ice hockey and rugby. The sports with a high rate of groin injury were ice hockey, and the football courts where field kicking is common, that is Australian football. And so after finishing epidemiology, let's discuss groin anatomy. Let's brush up some osteology. So we'll start from top of the right side. So first what we are saying is anterior superior iliac spine. Okay. Just after that we can say ligament of Cooper, then obturator canal, which is inside the obturator foramen, then the acetabulum, transverse acetabular ligament, and ischial tuberosity. At left we can see superior pubic ligament, pubic bone, interpubic fibrocartilaginous lamina, inferior pubic ligament, and your obturator membrane. Important structure which is starting from pubic tubercle and ending at anterior superior iliac spine is your inguinal ligament. It is very important to know the anatomical position of inguinal ligament because it is associated with lot of injuries in groin pain. Now in next slide we are gonna dig in depth about groin and a new concept which we call it as a groin triangle. Okay, so they have introduced this in 2008. It is new concept. I will request you all to go through that. You can get a lot of free full article about it. Okay, so here we are gonna just touch few topics about it. So you can see right side picture where we have a black border triangle. This is what we call it as a groin triangle. Now you can see 3 point or 3 apex and 3 sides. So we'll start with ASIS. From ASIS, when you draw a line till pubic tubercle, this is your superior border of your groin triangle. When you take again ASIS and go around the midpoint of your ASIS to superior pole of your patella, that point we refer as 3G point. Why 3G? It is groin, gluteal and greater trochanter. Okay, so it is an imaginary 3D structure. They have hypothesized this to refer different anatomical structures and classify different groin injuries. Now, when you take pubic tubercle and draw line till your 3G point, that will be your medial border of this anatomical triangle. So let's just discuss. So 3 apex, ASIS, pubic tubercle and 3G point, and 3 borders: superior border, medial border and lateral border. And there is something called as a contain or within what all structures there anatomical triangle. Now the next slide, the groin triangle, will go deep into a groin triangle. Will discuss structure surrounded and associated with each border and contain what is inside this triangle. So let's start with superior border, which starts from ASIS and ends at pubic tubercle. We'll start from pubic tubercle. So we are going from medial to lateral side. Superior to this superior border is the aponeurosis of your rectus abdominis muscle, then your internal oblique muscle, external oblique muscles and transverse abdominals. Now when we focus on just lateral 1/3 of the superior border, there are lots of nerve. So ilioinguinal, iliohypogastric and genital branch of the genitofemoral nerve. Okay, and deep to that is the conjoint tendon of iliopsoas muscle. So this was all about your superior border. Now when we consider medial border, which starts from pubic tubercle and ends at your imaginary 3G point, what all structures are associated with this? The main is your adductor group. So when we see from superficial to deep, first muscle is adductor longus and gracilis. These two muscles are most affected in groin injury. Then you have adductor longus and deep down you have adductor magnus muscles. So in medial border, all your adductor muscles and your gracilis. Now let's discuss our lateral border. Lateral border starts from ASIS and ends at your 3G point. Now everything lateral to this border, if anatomically we consider acetabular and femoral, that femoral hip joint is around this lateral border. Then you have a trochanteric bursa, tensor fasciae lata and IT band. This is all associated with your lateral border. Now let's see what is inside this triangle. Iliopsoas muscle, pectineus muscle, rectus femoris and femoral canal. These 4 muscles are inside this. Now when we hypothesize this border, we are not thinking it as a muscles. Okay, so these borders are not it is not any particular muscle is identifying this border. In fact, this border separate one muscular group from the other muscular group. Now after discussing all anatomy, let's see what all conditions we can identify around this triangle. We'll see first superior border, then medial, lateral and then within. So now when we're discussing about superior border, you're well versed with it. Starts with ASIS and ends at pubic tubercle. So the things which are underlined with blue marker are the most common injuries and then the other injuries. So what is more common is rectus abdominis tendinopathy. After that you can have incipient hernia, conjoint tendon tear. Conjoint tendon tear, when we are referring this, it is your transverse abdominis and external oblique muscle conjoint tendon. Okay, then you have incipient hernia, external oblique aponeurosis tear. Then inguinal hernia, when we are talking about nerve entrapment, because we have seen that there are n number of nerves also. passing through this area. So ilioinguinal nerve, iliohypogastric, genitofemoral, and there is something another nerve is lateral femoral cutaneous nerve. Okay, so this is all about the superior border. So whenever we are assessing any patient and any patient is showing you this location as their pain point, or the pain origin is around this area, you can rule out all these pathologies. Now when patient is having pain around medial border, that is the border starting from pubic tubercle till your 3G point, what all structures can be associated? The most common structure is your adductor or gracilis tendon. You can have enthesopathy. Now what is enthesopathy? Enthesopathy is nothing but pathology associated with attachment of tendon. Then you can have adductor longus muscular tendinous junction pathology. Okay. Next is pubic bone stress injuries are also common. Inferior ramus stress fracture, nerve entrapment of the obturator or ilioinguinal nerve or genitofemoral nerve, and external iliac artery and fibrosis. Okay, what is this? This is nothing but thigh discomfort after any high intensity exercise, and we usually observe this kind of injury in cyclists. Now this was all about your medial border. You can see one circle. Okay, this is your this circle is around your pubic tubercle. If you see pubic tubercle as a clock, okay, so when patient is complaining all 12 to 1 o'clock pain, you can associate that with your rectus abdominis. Okay, when patient is complaining 3 o'clock side pain, you can associate it with pubic symphysis. When patient is complaining 6 o'clock side pain, it is usually adductor longus tendon injury. When patient is complaining at 9 o'clock position pain, that could be inguinal ligament. We will discuss more about this pubic clock in next slide. But now we'll focus on the lateral part. So lateral border, which starts from ASIS and ends at 3G, what all pathologies we can see in that? So femoroacetabular joint impingement is very common, or labral pathology. So whenever you are treating or assessing side or lateral pain, you should look out for these injuries. Then there could be osteoarthritis of hip. Then you have a chondral damage in young patient. IT band friction syndrome is very common in runners. Femoral neck stress fracture, you should rule out this as well. Nerve entrapment of lateral cutaneous nerve occurs, meralgia paresthesia. You must have heard this from your professors. So this was all about the lateral side. Now next is what is within this. So what all injuries you can possibly rule out when patient is complaining pain inside this triangle. Very common is iliopsoas syndrome, then rectus femoris tendinopathy or apophysitis, femoral hernia, nerve entrapment of the genitofemoral nerve or the medial femoral cutaneous nerve. So this was all about the groin triangle. So in the previous slide we have discussed about the pubic clock. You can see, you can just Google this title and you can get full article and you can read in depth about this pubic clock. So this was all about anatomy. Now the third group is assessment. In assessment we will discuss this 4 step. First, define and align. So what you have to define after your whole subjective objective assessment, when patient is on the bed and you will start assessing them. You have to define anatomical positions where the patient's ASIS, pubic tubercle and 3G point and other borders. Then listen and localize. Step 2 is listen and localize. So listen patient history, their site of pain generation, and localize that site according to your groin triangle. Palpate and recreate. So you're gonna perform few tests and try to recreate the pain. Elevate and investigate. Elevate is like you can give them some rest or tension reducing position to rule out which part is associated with the pain. um, you can advise them for steroids injections to reduce the pain or rule out which part is actually associated. And when appropriate, you can suggest few radiological tests as well. Now we will start with the clinical examination. I can't go in detail all assessment, so I will start with few clinical assessment. This is Holmich approach. Now first what you can do is adduction of the legs against resistance and evaluate pain and strength. It's a normal adductor resistance test. Second, you can palpate the insertion of adductor magnus muscles at the pubic bone and evaluate the pain. Third, you can do is passive stretching of the adductor muscles, evaluate the pain. Palpate the symphysis pubis joint, evaluate the pain, and palpate the rectus abdominis muscles at the pubic bone and evaluate the pain. Anatomical triangle. Now, the next slide, the groin triangle, will go deep into a groin triangle. Will discuss structure surrounded and associated with each border and contain what is inside this triangle. So let's start with superior border, which starts from ASIS and ends at pubic tubercle. We'll start from pubic tubercle. Third is passive stretching of the adductor muscle and evaluate the pain. Fourth one is palpation of pubic symphysis joint. See, again they are palpating with one finger. But when you are palpating rectus abdominis muscle, you are palpating with two fingers. Make sure your patient is comfortable and you are not creating any discomfort. Now next 4 things. So we have discussed first 5 stages. Now next 4 stages. Functional testing of abdominal muscles. Then palpate the psoas muscles above the inguinal ligament. Functional iliopsoas test. Evaluate the pain and strength. And last will be your passive stretching of the iliopsoas muscles. The Thomas test. Modified Thomas test. And evaluate pain and tightness. Physiotherapist is performing functional testing of abdominal muscles. Ask for any discomfort, site of discomfort, and ask patient to scale that pain. Now palpate iliopsoas muscle. It is easy to palpate when patient is skinning. This is functional testing of the iliopsoas muscle. So the therapist is testing left leg of the patient. See, the hip is into the flexion, knee is into the flexion, and therapist is giving resistance with their full arm and not with their palm. So you have to manage, according to the strength. It is very difficult to give resistance with your palm when patient is using such a powerful muscle, iliopsoas muscle. Now next and the last one is the Thomas test, modified Thomas test. See the hand positioning and patient positioning. The leg which we are assessing is resting comfortably on therapist chest and patient is comfortable. So after performing all these 9 tests, you will be able to identify which structure is involved. So to help to do that, this is a Doha Agreement on Groin Pain Classification in Athletes. You can Google this title and you can get article to dig into. So there are three classification, defined clinical entities. So once after finishing your clinical assessment, you should be able to classify your patient into these four categories, that is adductor related, iliopsoas related, inguinal related or pubic related. If not this, rule out any hip related injuries. If not, that could be other structure as well, that is like inguinal hernia. If your patient is suffering from either of this thing, so what will be the clinical presentation? You can see first green box, that is iliopsoas related groin pain. In this you will get iliopsoas tenderness when you are palpating, pain on resisted hip flexion, we have seen how to perform that, and pain on stretching of the hip flexor in Thomas test. Okay. In blue box, adductor related groin pain, what all things will be positive? First, adductor tenderness will be positive, and second, pain or resisted adduction testing. We have seen how to perform that. In purple box, inguinal related groin pain, what all structures will be associated? First is the inguinal canal tenderness. Then pain in the inguinal canal. Patient will pinpoint that will be along the medial border, along the superior border. I'm sorry, not medial border. No palpable inguinal hernia. Pain with resistant testing of abdominal muscles or Valsalva maneuver, cough or sneeze. Now pubic related groin pain in yellow box, local tenderness of the pubic symphysis and immediately adjacent bone. We have seen how to palpate that. And next is no particular resistant test to provoke the pain. Okay. This is all about till classification and assessment. This is all my references. You can just Google it. Every article is free and you can read all these articles. It will be very helpful. If you like this presentation, then please like and share my page and subscribe. Aspire Physiotherapy and Rehab Center. Thank you for all your time. Thank you very much. Please keep checking for new videos and other stuff. Thank you very much.